you, Mr. Chairman. My name is Eva Pajkrt. I'm a professor in obstetrics, in particular prenatal diagnosis and obstetric ultrasound at the Academic Medical Center of the University of Amsterdam. I was trained as a gynecologist in the medical center Alkmaar, that's a general hospital, and afterwards in the Academic Medical Center in Amsterdam, that's a tertiary referral center. I was trained as a general gynecologist in all aspects of the specialty. Before and during my residency, I did my PhD on prenatal screening for chromosomal anomalies, and our work later on contributed to the national introduction of prenatal screening in the Netherlands. Following my residency, I did a 2-year clinical fellowship in fetal medicine at the UCLH University College London Hospital. Once I came back to the Netherlands in 2005, I started working again in the Academic Medical Center as a consultant in fetal and maternal medicine. I've been head of the fetal medicine unit since 2010 and was appointed professor in 2016. I'm involved in numerous committees of the Dutch Society of Obstetrics and Gynecology. Since the introduction of the prenatal screening program, I've been a member on several working parties concerned with the quality of care of the program, and I've been advising the Ministry of Health on several abortion issues. My presence here has been requested to answer your question about Dutch abortion care. The abortion care is embedded within the ethical framework of patient autonomy and is completely woman-centered. The objective of Dutch abortion care is to have a thorough and comprehensive process without creating any obstacles. I will briefly take you through the statement we have already received. I will not go through it extensively, but I understand some of the people are following this online only and they don't have this, so I will just go through it. I'll skip certain parts, so if you can't follow me, that's correct. Since 2016, there's been a national cooperation agreement between the Dutch Association of Abortion Specialists, the Dutch Psychological Counseling Service for Questions of Unintended Pregnancy, Adoption and Abortions, which is called the FIOM, Dutch Society of Obstetrics and Gynecology, and the Royal Dutch Association of Midwives, and which I forgot is actually the Dutch Society of General Practitioners. I see that it's not there, but they're also involved in this agreement. Women with an unplanned or undesirable pregnancy and doubts about continuation of the pregnancy will generally go to the general practitioner. So this is who is involved, which professionals are involved. In 56% of cases, women, the general practitioner will be the first contact. He or she may counsel the woman about her options, may refer the woman to the abortion clinic, a gynecology, or for further psychological counseling. They have their own national guideline, and I think I've also there's an English version which you have somewhere out there. In 25%, women go directly to the abortion clinic, and it's the first contact. The abortion clinic doctor may counsel the women about her options, they may perform the procedure, or they may refer the woman for further counseling. And then the other 25% either goes to a midwife or a gynecologist or some other professional. If the pregnant woman goes to the midwife may never be the referring physician. She's not legally a doctor, so she should refer the woman, and then the GP or the gynecologist has to refer the woman again. Gynecologist may be the first contact, or other doctors, like, for instance, women with a cardiac problem, in which it's unsafe to have a pregnancy, an ongoing pregnancy, maybe also referring people. Now, there's general considerations in case of unplanned and undesirable pregnancy. Now, one of the first things you ask is whether there was a pregnancy done, or whether you should repeat it. Then you should always ask if the pregnancy was planned or unplanned. Now, that seems contradictory, but it's, of course, not always that a planned pregnancy may become undesirable. An unplanned pregnancy may become desirable, and vice versa. Ask about the circumstances leading to the pregnancy and whether or not the woman was on contraceptives. Mention there is always a choice and a dilemma in case of unplanned pregnancy. Ask about a dating scan. If not, then please have one performed, preferably transvaginally. If the woman's determined to have an abortion, please mention that on your request to the sonographer. Is the partner present at the consultation, and explore whether the woman was not forced by the partner or the person sitting beside her, or that it's a voluntary request. Explore whether there has been sexual abuse. Be aware of cultural and religious factors. Ask whether there would be a risk of genital tract infections, but in case of abortions on request, as opposed to abortions due to prenatal diagnosis, we always test for sexually transmitted diseases in the Netherlands. We always discuss contraceptives. What kind of contraceptives the woman's going to use after she has had the abortion. Is the request consistent, or does the woman seem to panic and potentially may benefit from more time to make a decision? If so, refer the woman for further counseling. And when referring a woman for an abortion, always document the first date of the abortion request. There are several websites. I've added one. Women can go online. There is a choice and help choice, and they can go through it and then can do it. Then there's also a couple of questions you should always ask. Of course, are you certain about your decision? Seems obvious, but you have to ask it. How did you reach this decision? Is this your own choice? Have you considered other options? Would you like me to explain the options? Do you need help to make a proper decision? If the partner is present, please also ask the partner. And in case of ambivalence, it's important that the woman understands that she's responsible for her own choice. Ultimately, she is the one to make the decision. There's no one who's going to take this decision for her. Do not force a woman into making a decision. Try to help her making a choice. Do not blame the woman for being ambivalent. Consider the emergency situation of the woman. If the woman remains ambivalent, refer the woman for further counseling and to the FIOM, which is the Dutch Psychological. That's actually, the FIOM is also the agency that helps people further who consider adoption. And they actually, once they go on with adoption, they help these women. Well, time is very important in any case of unplanned pregnancy in view of the method of abortion. So once a woman is referred, a quick appointment is mandatory, so preferably within a week, but at least within 10 days. From the moment a woman indicates she's considering an abortion and the actual treatment, a reflection time of at least 5 completed days is mandatory in the Netherlands. This reflection time is not mandatory until gestational age of 6 weeks plus 2 days, which is the 44 days Chef mentioned after the first day of the last menstrual period. However, 65% of these women do have a reflection period of more than 5 days. There's several ways to terminate the pregnancy: a surgical one, a medical one, and a combined one where we use medication followed by surgical procedure. Women may choose where they have their abortion and how they have their abortion, although their choice is, of course, also dependent on gestational age. Women over 16 years do not need parental consent. Women between 12 and 16 years do require parental consent, but we can withhold parental consent if we think it's a reasonable argument. The majority of abortions in the Netherlands, 90%, is carried out in abortion clinics. Then the Dutch Healthcare Inspectorate produces an annual report which statistical information about terminations performed in the Netherlands during the preceding years. And the last report was for 2015. Due to the manner in which the abortions are in which these data are gathered, it's aggregated data, so it's not possible to correlate between the different components of the abortion registration. So a couple of numbers, so just so we know what we're having. In 2015, we had 30,000 abortions in the Netherlands. Almost 4,000 of these were from women from a foreign country, 13%. Of all the abortions, 8,500, which is 28%, were before 44 days. So these are don't even are considered under the Abortion Act. 16,000, so 50%, were performed before 7 weeks gestation, while 9,000 almost were performed between 7 and 12 weeks. Thus, 80% of all the abortions were performed in the first trimester before 13 weeks. Did I say something about that? No, I'll come to that. The majority of women undergoing an abortion are between 25 and 30. Only 83 pregnancies were terminated in women younger than 15 years. The total number of pregnancy terminations in teenagers was 3,000 in 2015, and that has been decreasing slowly over the last couple of years. And this is also reflected in the percentage of teenage pregnancies in general, also those that go to term. And this is very low compared to other European countries. Since 2007, all pregnant women in the Netherlands may undergo prenatal screening. They are offered a combined test for screening for Down syndrome, Edwards syndrome, and Patau syndrome. And as of 2017, NIPT has been added as a first trio test to screen for the above-mentioned trisomies. Moreover, every woman is offered a 20-week scan. Since 2011, it is possible to address whether an abortion is the result of prenatal diagnosis. In 2015, only 1,000, a little bit over 1,000 of all abortions were performed after prenatal diagnosis, and a majority of which was in the hospital. So we do know from the aggregated data that more than 30% of the abortions in hospitals is due to prenatal diagnosis, compared to only 0.5% in abortion clinics. However, we do not have any knowledge on diagnosis, nor is it possible to correlate the date with gestational age. It is likely that abortion due to prenatal diagnosis will be carried out in the second trimester due to the time it takes to get a definite diagnosis. Thus, we can assume that around 20% of the second trimester abortions is due to prenatal diagnosis. Some final considerations. Of all women undergoing abortion, 75% leave the clinic or hospital with a prescription of contraceptives. Since 2012, it's mandatory to provide sexual education to all school-going children. This starts in elementary school. Till 2011, contraceptives have been reimbursed for every woman. Since 2011, only women up to 21 years get reimbursement. Abortion is free in the Netherlands. As long, it says that's wrong in the statement, it says it's for everyone who's legal and insured. It's not true, it's for everyone who's legal and has a social security number. It is subsidized care, so the costs are not reimbursed by the insurance company, but it's subsidized by the Ministry of Health. For foreigners or people living illegally in the Netherlands, costs vary between 380 and 940 euros. There are certain centers, such as the Academic Medical Center, that are subsidized separately by the Ministry of Health to take care of these women. So if women really are in a very difficult position and cannot afford an abortion, our hospital will provide an abortion and they're reimbursed a different way. I don't know exactly how it's regulated, but there's a subsidy for that as well. Thank you very much for your